Hey, welcome back to the third module on how to support your client through an induction. We are going to talk now about monitoring contractions either externally or internally, and then I'm going to also give you some tips on how to help your client prepare for an induction and the longer cervical ripening stage. So, okay, with an induction, they are going to start with external monitors, and those are the ones that just go on your tummy. You're going to have usually one that measures contractions and one that measures the baby's heart rate. And as you can see on that printout, I have a picture of what that looks like. The bottom section is going to be the uterine contractions, so where you see like those little hills. Each one of those is a contraction. And then the top would be baby's heart rate. So the nurses and doctors, providers are looking for like how often she's contracting, how long they're lasting, but they're also looking at like, is baby responding in a negative way to the contractions, and if their heart rate is dipping, and everything means a different thing. So like if the heart rate is dipping a little bit before a contraction, that's usually okay and like a good sign. If they're dipping during the contraction, that means a different thing than if they're dipping after a contraction. And so they're looking for all kinds of things through fetal monitoring that us as doulas don't have that knowledge and like training to be able to read this correctly. So that's just kind of a little tidbit on monitoring. Now, what you need to know as the doula is that when it's external, when it's just on the belly, all it's measuring is the pressure of her uterus externally. If her belly gets hard, that is going to push a little button that's on that disc that's sitting on her tummy. And so then that will measure a little bump, which could mean a contraction. It could also mean she's laughing or she's straining or she's moving or uncomfortable. Like it can pick up all kinds of movement and things, and so it's not an exact science. But when we get it in the right spot, it should be measuring contractions. And all it's telling us is that she is having contractions. It's showing us how long they're lasting, how frequent they're coming, and what baby's response is to that. It doesn't tell us how strong the contractions really are. So if you notice like a little teeny tiny hill of a contraction, those could actually be really super strong, good contractions. If we're noticing a huge hill, that doesn't mean it's a super strong contraction. That could be a baby contraction. So don't let the height of that hill does not equal the intensity. The only way for us to know intensity is if it's an internal monitor. So that is something I usually end up explaining to dads and moms because they don't know that. They think, oh, that's a really big hill, so that must be a really big contraction, which isn't true. Okay. When we start Cytotec or Cervidil or a balloon catheter or any kind of cervical ripening, almost always it's going to give some contractions. However, they're really minor. They're not like even really real labor contractions. They're usually just like irritability contractions from that medication or balloon. Now, often a nurse will come in and she'll look at this monitor and she'll be like, oh my goodness, you're having contractions. Do you feel those? And that gets the mom all excited, like, oh my gosh, I'm having contractions and I don't even feel them. And that is so great. That must mean like I have a really high pain tolerance. Things are going to be progressing. I won't even feel it or know it. Or like you get it kind of like amps a mom up to think like, yay, I am contracting. That is so great. When really I want the mom to do the opposite. I want the mom to not focus on contractions, especially contractions that she can't feel. Pretty much every pregnant person is going to have some contractions that they don't feel if you hook them up to a monitor the end of pregnancy. That is normal. That is okay. That doesn't mean you're in labor. So, that's a little tidbit you can mention to your client. But before I kind of get into that, I'm going to also talk about internal monitoring. Okay. If we need to accurately measure contraction strength, this isn't usually something that we need to do right off the bat in an induction, but later on, once you're kind of in more active labor, this could become an intervention that is helpful in some cases. So they would use something called an intrauterine pressure catheter, which is also called an IUPC. It is a thin, flexible tube that's inserted into the uterus. And so that means your water has to be broken for this to get inside. Sometimes, if this is something that is really needed, they might have to break your water to get this monitor in. Now, what this is doing, it's not like attached to baby, it's just sitting next to. This intrauterine pressure catheter is accurately measuring contraction strength, whereas the belly bands do not. So this is actually recording the pressure within the uterus, which is calculating the MVUs. The MVUs are kind of giving us like a mathematical equation on how much pressure each contraction is giving. And you should be at like a specific amount of MVUs per 10 minutes. And that equation equals like your cervix, if it is doing these strong of contractions, it should be making cervical change and dilating. So say you've been on, I say you, but your client, say your client has been on Pitocin for 10 hours and she's 7 centimeters, and that is great. And she's having strong contractions every 3 minutes, like active labor pattern, everything looks good. And it's been like 6 more hours and she's still 7. Okay, that is something's going on there, right? And to us, everything looks okay contraction wise. Like her contractions are strong, they look strong. She's acting like they're strong. They are coming every 3 minutes, like they're very consistent. We don't need them closer together. It doesn't seem like they need to be stronger from how she's acting, but why is she not dilating? So this would be a situation where this intrauterine pressure catheter could be helpful. Maybe her Pitocin is at like 20, which is kind of the max around here in the Seattle area that they will go. Sometimes they'll go up to 25. Sometimes they'll go above that with like provider permission, depending on the scenario and the situation, but that is not very common. Okay, so say she's at 20 of pit, which is a lot, and no cervical change after like a long time, 6 hours. So now we talk about, okay, let's consider breaking your water and putting in this pressure catheter to see really what's going on, because a provider at this point, they're not just going to want to like keep going up on Pitocin if her contractions are adequate. If they're adequately strong and there's something else going on as to why she's not dilating, we don't want to just crank up the pit, because that's going to make her possibly have like a uterine rupture, and that would be terrible. So for safety of like dosing Pitocin, this will give us the information we need. So we put that catheter in, and that's going to tell us pretty quickly, within about 10, 20, 30 minutes, if her contractions are adequate or if they are not adequate based on the MVUs. And if they're adequate and she's not making cervical change, then like something else is going on. If they're not adequate, even though they're 3 minutes apart and they seem really strong, we know that we can still increase the Pitocin to make them stronger and that we're not like overstimulating the uterus. So we're doing that safely based off of the MVUs. So I hope that that makes sense. That's kind of a lot of information, and I hope that I'm not confusing you. If I am, message me, please. I would love to chat more. So these are not like always a bad intervention. Sometimes they can be helpful in still achieving a vaginal birth, like safely. So, okay, there's what the kind of difference in monitoring would be. And now we'll go to how to help your client navigate the cervical ripening stage. So, this is what I tell my clients when they are headed into an induction. I would remind them, you need to eat and hydrate. Bring a million snacks for not just you, but also for the partner. Bring electrolyte, like good quality, high quality electrolytes. Sleep as much as you possibly can. Because when you have passed that window of getting a nap, your window is gone and you cannot get a nap unless you get an epidural. And even sometimes then you can't nap. So get this sleep because that is going to make coping with pain and decision making and emotions a lot easier. Also, I want you to ignore this as long as you possibly can. And when you cannot ignore it anymore, you're in early labor. You're not even in active labor. And so really ignore it. I tell people like you kind of have to gaslight yourself and just play it's a mental game of like, I'm not in labor, nothing is happening. This is just ripening. Like this is nothing. I'm not even dilating. It's not it. It's not it. It's not it. Like you have to mentally play that game. And that is how people can cope better when things do get hard. And then repeat all of that and do that as long as you possibly can. So remind them this cervical ripening stage is long and it's hard because if you went into labor on your own and you were at home, it's still hard to ignore this part and this time, but you're not even there. You're not even in early labor yet. You're like in a prep stage. But the hard part is that you're not home. You're not comfortable. You have nurses coming in, you have beeping going on, you have like laboring neighbors that are loud, you have an uncomfortable bed, you have, like it's so not easy to get sleep or ignore it. And you feel like you're there, so you're focused on it, and everyone's asking you questions about, did you feel that contraction? Are you noticing anything? So you're like hyper focused, which is really the opposite of what you want to do. So it is hard. It's a hard environment to ignore it and try to downplay. So mentally set yourself up for that. Often hospitals will start inductions in the evening or late at night, kind of like 9, 10, 11 p.m., midnight even. And that's because they know that for the first at least like 12 hours, probably if not 24, not much is happening, and they're just like getting you admitted, they're getting some cervical ripening on board, and the goal is for you to sleep. So if you are like, whoa, why are they scheduling this at night? It's because they know you're coming there to sleep while this kind of stuff is going on in the background, and they would rather just start that at night than in the morning for your sake. So very, very common for that to happen. Okay, a pro tip would be if you are checking in the evening or nighttime for cervical ripening, I would highly, highly, highly recommend to my patient, my client, that they ask for a sleep aid. So depending on what hospital you're at, sometimes they can give Ambien. It could be morphine, it could be Nubain. Ambien's a sleeping pill. Nubain and morphine are narcotics. However, those are going to work so much better and be longer lasting than like a Benadryl. So they do sometimes offer Benadryl or fentanyl. However, I wouldn't recommend fentanyl just for sleep in early stage, because that only lasts maybe an hour. And so that's just not very helpful. The Benadryl can work fairly well for people who are really sensitive to it. Like if Benadryl kind of knocks you out, that might be enough for you. But I find usually, even for people who are like, oh, a Benadryl will be fine, like that will work for sure. Usually it just doesn't. And the reason is you're in the hospital and you're not in labor. And so it's so hard to sleep. Your nurse is going to be in and out every like 2 to 4 hours to adjust monitors, giving you another dose of medication, doing vitals, etc. You're going to have lights and beeps from all the monitors and machines. There's, like I had said earlier, there's loud laboring neighbors sometimes. Nurses, you can usually hear them like laughing or chatting out in the hallway or the nurse's station. You're in the world's usually most uncomfortable bed. You're not at home. Your partner's not like they're there, but they're not in bed with you. It's just so hard to sleep because you're also pregnant and it's hard to sleep anyways. So especially if you are wanting to go unmedicated, take the sleep meds. The stronger, the better. I will tell you that people never ever regret taking them. I have never had one person regret taking a sleep med, but I have had many regret not taking a stronger sleep aid, because probably the worst thing you could do is not take anything or take something that really isn't going to work well, and then you get a horrible night of sleep. And then the next day, you're still not in labor, but we're trying to get labor started. And you don't want to have like a horrible night of sleep before you've even like started labor, because you're going to probably for sure miss another night in hard labor. So it's just not setting you up for success. People can handle pain so much better when they are rested. So just another little tip there. And I would not think of this as like I needed medication to get through labor. Like this isn't even labor yet. You're not utilizing that for that. You're utilizing this for sleep so that you can get through labor. So don't think of that as like a negative. Okay, I digress. We will move on. Okay. What should your client do and what should they focus on? I usually send them a message, like, or have a phone call or a FaceTime like a day or two before and kind of remind them of all of this. But I encourage them to make their room comfy and cozy for them, so they can bring like twinkle lights and battery candles, and their own pillow is so important, and like a soft blanket or their own jammies. Soft music and eye mask can be really helpful to kind of like drown out some of the lights and monitors and stuff. Earbuds can be helpful, a smell that they like, all those kinds of things to kind of make it feel more like their space. And this is more important for an induction than if someone went into labor on their own, because they're going to be there for a long time and they're going to be there for like a day of not being in labor. So I want them to like appreciate and notice the space versus, if someone's in labor and they kind of show up in active labor or transition, they're not going to even probably notice their space very much. Whereas with an induction, they do. So I encourage it a little bit more. And then just remind them to be mentally prepared that this is going to take a long time and slow and steady wins the race. I remind them to ignore all sensations, cramps, contractions, ignore all of it until they become hard enough that they have to focus on it. They can utilize nitrous or IV pain meds to get through like a balloon placement or to help them sleep rather than jumping like straight to an epidural right away. They can absolutely ask to take breaks from monitoring so that they can like take a shower and eat, or like even sometimes they can like take a quick walk around the hallway or outside and like get some more kind of fresh air or different environment for their mood. And then I really recommend don't recline. Try to stay really forward leaning or sitting straight up or side lying. That's going to help promote baby getting into a better position for birth. And then they should totally bring entertainment because, again, this is a long process. So books or podcasts, movies, puzzles, games, all of that kind of stuff that they can like have something to do to pass the hours while they're waiting. And then sleep, sleep, sleep. So important. I already talked about the sleep aid. And then when it's daytime, a lot of times people are like, what should I do? Like, what kind of circuits or positions are they're like, should I start pumping? Should I start like, doing this, that, and the other thing? Honestly, yeah, you totally can. And I think doing some circuits is always a good idea. I usually would send people different ones to kind of do throughout the day. But when you've done that and you're done, take a nap. Like, eat and hydrate and sleep. This is your time to like bank up on that sleep. We don't need to be doing tons of positions until things really start going and we're like having active labor contractions. So that's my personal opinion on that. Obviously, there's not a huge right or wrong. That's just my 2 cents. I think in this kind of waiting stage, that sleep is more important than doing things physically to try and get labor going, because usually it doesn't work. So if you're being induced, like, we're probably going to have to use the meds. So unless your body's like teetering on that anyways. So sleep, hydrate, ignore, repeat, 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 repeat. Okay, I think I have laid it into you enough. Hopefully you get my point. Okay. Now we'll talk through about breaking water, which can also be another intervention that is suggested along with adding, starting Pitocin or things like that. So there's pros and cons to that. The pro would be when your water bag is broken, it releases prostaglandins and hormones, which can help facilitate labor progress a bit more naturally, because those are your own hormones and your own prostaglandins and your own body kind of kicking into gear versus like artificial things. Also, when that bulgy bag of water is gone, it allows the baby to descend more and like drop further into the pelvis. And that's going to put more direct, firm pressure of that baby's head on your cervix, which is going to help labor progress, usually a bit faster as well. So those are the pros. The cons would be that it can sometimes make labor contractions feel more intense. And once that bag is broken, we can't put it back. It's broken forever. And the chance of a uterine infection does start to increase. And so now most of the time you're kind of a little bit more like on the clock, where we want baby to really be born within, hopefully 18 to 24 hours. So statistically, the chance of infection starts rising around 18 to 24 hours after the water has been broken. However, it could happen at any time, and we have no idea what is going to happen for you. So I will say that I have seen people with their water broken for like 2 hours and they get a raging infection. And then I've seen people with water broken for like 44 hours and they don't have an infection at all. So we really don't know when or if it ever will happen to you, but just the fact that it is broken is going to like increase the chance of that statistically. So I personally, this is again my personal opinion, would not recommend breaking water before 4 centimeters for sure. Preferably more like 6 or 7 centimeters, maybe 5 for an induction. I think that that is pretty appropriate. Because you're in a little bit more active labor, things shouldn't take like too terribly long. When you're still at like 2, 3, 4 centimeters, it could be a long time still, and then that risk of infection is going to rise. So that's just my 2 cents on that. And then here's a little information on some things to think about before deciding to rupture the membranes. Think about the medication plan. So if your client is wanting to avoid an epidural and hopes to go unmedicated, breaking the water can be beneficial because it could kickstart her own labor, which could be a bit of a more gentler process consisting of her own natural hormones, her own contractions, etc. If she's 3 to 4 centimeters dilated, like before, Pitocin is started, especially if it's not her first baby, sometimes breaking the water is like all that they need to really put them into labor. If it's her first baby, I probably wouldn't recommend until she's at least 4 centimeters. Again, kind of what I had said on that other page. Okay, baby positioning is another thing to consider prior to breaking water. So it is always a good idea to try and assess what position baby is in, because that bag of water gives them a cushion to like move around in and be able to move positions better and navigate the pelvis better. So if we already know that baby isn't in a great position, then it's a good idea to not break the water so that the baby has room to rotate and move and get in a better position first. If the baby's in a great position, then sure, break the water and they'll just kind of like sink down in that good position. The other thing to think about, which I had already mentioned, is infection risk and time frame. So although we don't know how fast or slow labor will be, the closer to active labor, 6 centimeters, the chances of labor being, birth being more imminent. So ultimately, that's going to be a less risk of infection than if we know, hey, this could still be a really long time. So the later you break it, the better, or the less risk of infection. And sometimes once we get a bad infection, that can potentially increase the likelihood of needing a C-section if we're still far from birth. So many providers will want to start Pitocin and break water at the same time. I would avoid not doing that, especially if the client wants to go unmedicated. So a lot of times their protocol is like, let's do a couple doses of miso, then let's do like a Foley balloon and start Pitocin, and then we'll break water, or we'll do like a Cook's catheter, and then when that falls out, we're going to break water and start Pitocin. And that's just kind of like throwing a lot at you and really plummeting you into, whoa, a lot more than the pace maybe your body wants to go at. And that can be really hard to handle and cope with if you're hoping to go unmedicated. So if that's the plan, just do one thing at a time. Don't double it up unless we really have to for some good reason. Okay, we will stop there, and then next module we will talk about Pitocin.